Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have our presenters in conference. Please be aware, each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the Q&A pod located to the left of your webinar platform. You may also download a copy of today's presentation using the Resources pod located directly below the Q&A pod. It is now my pleasure to introduce today's first presenter, AJ moderator, Laura Castellanos. Please go ahead.
Hello, everyone, and good day. I'm Laura Castellanos, Associate Director at the American Hospital Association. Thank you for joining us today. We're delighted to bring today's webinar, Leading Practices for Screening and Assessment of Human Trafficking Victims. The AHA's Hospitals Against Violence initiative is proud to partner with Heal Trafficking and Jones Day Law Firm. This past year, we have worked together to bring a series of webinars like this one, covering a range of topics. We look forward to continuing our efforts to advance this work. Today's webinar will provide resources and best practices, techniques for healthcare professionals to screen and/or assess for labor and/or sex trafficking. The session will share strategies, screening and assessment tools, and explain the limitations of existing instruments to assist hospitals and health systems in providing trauma-informed and person-centered care. At the AHA, we are committed to raising awareness of this public health crisis and aiding our hospitals and health systems in combating human trafficking. So we're pleased to share that last year the new ICD-10 codes for human trafficking were approved by the CDC. We want to make sure we work together with all of you to learn how we can best support your work. So please visit us and reach out to access our key resources. You can visit our website, and you can access resources around the new ICD-10 codes as well. So let me introduce today's speakers. Holly is a program director for patient care services at Dignity Health, one of the largest health systems in the nation and largest health hospital provider in California. Holly oversees efforts to educate Dignity Health staff about various forms of violence, including human trafficking, and how to support victims and survivors using a trauma-informed approach. In 2014, Holly published an academic book titled Walking Prey: How America's Youth Are Vulnerable to Sex Slavery, and she's a current blogger for the Huffington Post. Also with us today, Dr. McKinney Chisholm Straker. She's a co-founder of Heal Trafficking and an assistant professor of emergency medicine at the Icahn School of Medicine at Mount Sinai. She works clinically at Mount Sinai, Brooklyn. Since 2005, Dr. Chisholm Straker conducts original research at the intersection of health and human trafficking in the U.S. She educates healthcare providers on how to identify and treat this patient population and trains advocates and not-for-profit organizations on human trafficking and the latest research in the field. We're delighted to have you both. Handing it over to Dr. Chisholm Straker.
Hi, thanks, Laura. So as Laura said, I'm McKinney Chisholm Straker, and I'm going to be talking with you first about a definition of terms. And just to make it clear, especially for the clinicians and the folks that are working in hospital settings, I don't use the word victim, especially when I'm talking about what we're doing, our work in the clinical setting, because everyone we have is a patient, and it doesn't matter whether they're innocent or guilty of anything. Our only job is patient care, and I think that using the term patient helps us reframe and always keep that idea center in our mind. I do need to disclose to you all that my research is currently supported by the Robert Wood Johnson Foundation in addition to the hospital where I work, and was previously funded by the Emergency Medicine Foundation. That being said, I want to make sure we're all talking about the same thing, and I know that everyone on the call may not be a trafficking expert, so really briefly, let's just go through the definition of human trafficking, the federal definition. Everyone should be aware that their state may have a different definition of trafficking. The UN has a different definition. Every country has a different definition. We today are talking about the federal definition that has been in existence since 2000. So human trafficking is the recruitment, harboring, transportation, obtaining, and/or provision of a person by the use of force, fraud, and/or coercion for the purpose of labor and/or sexual exploitation. The important thing for everyone to pay attention to is there are 3 columns, so 1 plus 1 plus 1 equals trafficking. I think a couple things we just want to point out really quickly are that transportation is not actually required for human trafficking to be determined, and that I put labor trafficking and or sexual exploitation because that's how the law defines it, but it's really important for us to remember that people are traumatized and exploited in multiple ways. There is an important caveat that is related to age, and that is if a person is under the age of 18 and is engaged in any kind of commercial sexual activity, that is human trafficking. I won't get further into caveats there. That would be a whole other webinar, but just to make sure we're all on the same page. So now that you've sort of gotten the lay of the land, we are talking about a definition of terms, and I want to make sure that we're all using these terms appropriately and thinking about it from a clinical setting, especially for folks who are in leadership. These terms are important because clinicians use these terms every day, and we know what we mean by them, and administration sometimes means something different, and we want to make sure that we're all meaning the same thing, especially when we're coming up with policies that impact patient care, because our actions are not benign just because they're well-intentioned. So first, let's define screening. Screening is a diagnostic instrument, or it is when a diagnostic instrument is applied to an entire predetermined population in an effort to identify the possible presence of an outcome of interest. So I underlined a few things I want us to make sure that we are clear on and that we always keep in mind. A diagnostic instrument. This is something, it's a tool. It is actually a tool. And it's applied to an entire definition or entire group of people. That group of people could be a group of people who all present with abdominal pain, or it could be all women of childbearing age. It could be all people over the age of 64. So as long as the population is predefined, it can be a population. There isn't a demographic or something like that that makes something a population for this. And it's the possible presence. It doesn't necessarily tell us that someone has or doesn't have a thing. It just tells us that they may have this thing, and this person may warrant further assessment. When we think about the purpose of screening, especially when we're thinking about trafficking, we want to remember that it allows for patient disclosure or issue recognition regardless of user bias. This last part is really important. It's regardless of user bias. That's the whole reason that there's a predetermined population. This way, we're looking at the people that we think are most likely to have the thing we're thinking about, and we're not deciding, oh, well, based on the reason that they're in the emergency department today, or based on the reason they came for their to the clinic or the office today, we're not worried that we're missing something. This way, there isn't user bias. So some clinical examples, just to make sure that we're all clear on what screening might look like in a clinical setting, in a healthcare setting. A urine pregnancy test. So of women-identified people who are of childbearing age, which apparently seems to be getting younger and older all the time. So I would say somewhere from 9 to 55, because pregnancy can actually happen in someone who has ovaries and a uterus before the first period, actually, or before the first menses. You want to have a larger catchment area, and that's pretty simple. It's a screening test that's actually very simple. It's so simple that we let people buy it at the local pharmacy and say, if you pee in this cup and dip a stick in there, and it's positive, then it's positive. It's the same thing that we use at the hospital. People think that it's more fancier, but it's not. Intimate partner violence screening questions. These are questions that, according to the U.S. Preventative Task Force, we should be asking all women-identified people of childbearing age for whatever reason they present to, for example, an emergency department. Regardless of, they come in for a laceration while cutting dinner, they came in for chest pain, they came in for abdominal pain, they came in because they were lightheaded. Everyone is supposed to get asked. That's a predetermined population. Ebola exposure screening questions. I can't speak for every state. In New York, we now screen for Ebola since the 2014 pandemic. And the goal, of course, is to isolate anyone who might have Ebola. Now today is we have the biggest measles outbreak we've had since 2000. And so anyone that comes in with a certain set of or constellation of symptoms and history gets put in the room by themselves so that we make sure that if they actually have that thing, we don't spread it to the rest of the community. Screening is different from assessment. Assessment is an evaluation by an expert when there is a concern for an outcome of interest. I highlighted expert here, and again, concern. So expert is highlighted because for screening, you don't have to be an expert, right? I never said anything about expertise in screening. In fact, I said, for example, for the urine pregnancy test, you can just go, anyone who has cash or plastic can go to a pharmacy and pick up a screening test for pregnancy. But an assessment requires expertise. And again, it's not saying that I know you have this thing and that's why I'm doing the assessment. It says that I'm concerned about this thing, and so I'm going to do this assessment. The purpose of it is to activate experts and facilitate purposeful resource allocation. For a lot of things that we're concerned about in the healthcare setting, it's not appropriate to test everyone in depth or assess everyone in depth for that thing. So just to give you a few examples that we use in the clinical setting, the easiest one I think of is the pulmonary embolism assessment. So pulmonary embolism, for those of us who aren't clinicians, is a blood clot in the lungs that can be life-threatening. Everyone who comes in with chest pain could have a PE, but most people don't. So how do we figure out who those people are? An expert, so the attending physician or the PA or the nurse practitioner, has to decide, is this person high enough risk that I'm going to test for it with one of these things? A D-dimer is a first start. That's kind of like the screening test that only an expert can use, so that's a poor example. Or a CTA chest or a VQ scan. You don't really need to know what, getting into the details here, I don't want to get into the bushes, but these are tests that only a clinical expert should be deciding who with chest pain or who with shortness of breath should be going through that, because these aren't riskless things. For example, a CTA chest is a CAT scan. That's a lot of radiation. It's an angiogram, so we're sending contrast through your body that your kidneys have to process. That can cause renal injury. So it's not a benign thing. We want to make sure that an expert is deciding that this risk is worth the benefit. A child maltreatment assessment is more akin to a trafficking assessment, in that there isn't one clear test, right? When a clinician is concerned about child maltreatment, we actually don't do an in-depth investigation. We, based on the history, the exam, and whatever we're seeing play out in front of us, we decide whether or not we're concerned, and then as mandated reporters, we call the actual experts to do an investigation. Even the social workers in the hospital don't decide whether or not it is child maltreatment. They might facilitate the call to, for example, Child Protective Services or whatever your mandated reporting system is in your state. Other clinical examples are a pelvic sonogram for an ectopic pregnancy or an ultrasound or a CAT scan for appendicitis. These tools, an ultrasound or a CAT scan, for example, cannot be used by just anyone. Only an expert technician and an expert radiologist can get the images that are needed and interpret those images so that we can decide whether or not someone needs to go for surgery, which is a pretty big deal. So you can't just have like the medical student come in and say, well, they have an abdomen, so I'm concerned that they have an ectopic pregnancy, so I think we should do this thing, and I'm going to read it and decide. It requires an expert to use. Now, I want to get into validation because I think a lot of folks get excited about screening and assessment and say, okay, well, I'm going to come up with some tools. And I think the intentions are well placed, but if we're not validating our instruments, we're missing a big step. So validation is the comparison of a new tool against a logical or gold standard, not expert opinion. So this means that we're asking ourselves, is this new thing that I've come up with, that so-and-so has come up with, that is, on the internet, is it as good as the thing that we know is the gold standard? So we'll get into a little more details here, but first, why is this important? Validation is important because it tells the user that the test actually measures what it purports to measure, right? So if we're screening for trafficking with the tool that we've made up, but we haven't actually tested to see if it measures what we think it measures, are we picking up trafficking? Are we picking up something else? Are we not picking up anything useful at all? So a couple clinical examples, validated and unvalidated. Urine pregnancy test, tested, years, we know this works. If someone, and we know when it works, that's the other thing. So we know that in the first few days, the first couple weeks of pregnancy, we might miss it if we're using a urine pregnancy test. But outside of that, it's really quite good. ITV screening. There are intimate partner violence screening tools that have been validated. Those are the ones that we should be using clinically. Ebola screening questions. They're not validated. We came up with them during a pandemic. It was an emergency situation. We needed to make sure that we had a really wide net cast so that we didn't miss anyone who might have Ebola, because the risk was too great to allow that possibility to go through. The risk of quarantining temporarily someone who didn't have Ebola, there isn't really, I mean, there's the risk of, like, you know, I didn't get to go to work and I missed my kids and that kind of thing, but in the long run, for that person and for that community, making sure that they don't have Ebola is more important. And the government has said this, so, like, I'm not making these things up. We've decided there are certain things that we're willing to say personal freedoms do not trump what we actually need to do for the community. D-dimer, CTHS, VQ scans, we're looking for a blood clot in the lung. Alternative to a CAT scan and a VQ scan is taking someone to surgery or going to autopsy. Those are the gold standards. That's what we're comparing it to. So if we come up with another test that looks for pulmonary embolism, we need to make sure that it's at least as good as our gold standard now, CTHS. And that was, you know, compared to looking into someone's body directly. Obviously, that as a gold standard is a pretty high bar and not risk-free. But it's not expert opinion. It's not someone saying, oh, I developed this new thing and I think it's really great. You should buy it. You should use it. Because they definitely have some, you know, some skin in that game, as they say. And then the last term that people sort of bandy about is protocol. Protocol is an algorithmic set of actions that mobilizes a dedicated team when an outcome of interest or concern for said outcome arises. The two things that we've underlined here are algorithmic and dedicated team. It's an algorithm. It's a pathway. You do this when this happens. And the point of it is to mobilize this team. It enables reliable actions regardless of the users. Those of you who have heard me talk about this before have heard the stroke story. You know, the bat phone rings in the emergency department, and EMS tells us that they're concerned about stroke for someone and they're coming in 3 minutes. And regardless of whether or not there is a doctor in the building, things start moving, right? The CT tech gets ready. They get the person that's currently on the table off the table. The neurologist is made aware wherever they are with their cell phone access. Everyone who might take care of this patient is now ready. We have a bed ready. We're ready to transfer them, the whole thing. That's the protocol. Child maltreatment concerns. There's a protocol. As the clinician, I'm concerned that this child might be maltreated in some way. If I have a social work team, alert the social work team, and then the next step is one of us calls, you know, our central child registry, and whatever our hospital protocol is in addition to all of that. Or for BLS, basic life support, no meds involved, it doesn't require anything more than someone who can push on someone else's chest. You check a pulse. Are they breathing? Are they responding to your questions? No? You begin pushing on their chest. That's an algorithm. The transfer of a patient is another one that, you know, we're not physically doing anything to the patient besides moving them from point A to point B, but how do you get that going? You recognize that the first thing you do is decide, do I think this person needs to be transferred, and to where? And then what are the steps that you go through to get that person transferred? The only example that we have in the healthcare setting, I'm not speaking about social service settings, specifically for a hospital, clinic, or office-based setting for screening for human trafficking, is the Greenbaum tool. It is, however, for a very specific group of people. It's for a predetermined set of people who are, frankly, they're adolescents, but are minor adolescents, so 13 to 17, that speak English with certain complaints, and it's only to screen for sex trafficking. So we're missing a major form of trafficking that we know, based on recent literature in the past 5 to 7 years, that young people experience. We're missing labor trafficking. If you click on the hyperlink later when the PowerPoint is available, if you click on that, that'll take you to the Greenbaum tool so you can think about what specific complaints you might want to be thinking about using that for. But But that is the only tool that is validated for the use of screening of trafficking in a healthcare setting. So that means we're not able to yet screen adults in a validated way. We're not able to comprehensively screen minors for labor and or sex trafficking. So what are we supposed to do? In absence of validated screening tools that are comprehensive, we're supposed to do the thing that the stethoscope encourages us to do, which is to listen. The webinar did not stop, you just kept listening. That's what I want you to do, is remember to keep listening, to allow for pauses and uncomfortable conversations to take place. You need to leave space for that. So medicine, frankly, hasn't changed a ton in how good we are at doing this, but I think we're certainly moving on the right trajectory. So this is a comic, I guess, from the 1880s, where this doctor, who you are to assume that the doctor is the man, and the patient is the woman, and if you read the caption, it becomes clear. They don't even tell you that the doctor is the man. It just says old lady, so you have to assume that the man is the doctor. So he's talking to her, and that's actually how the conversation goes, and it's clear from this conversation that there's been a misunderstanding. So the old lady asks the physician, "Tell me, doctor, what do you consider the most important rules for all health?" And the doctor says, "My dear madam, always live on gravel." And the old lady replies, "Oh, doctor, I'm sure I couldn't digest it. There's been a misunderstanding, obviously. There wasn't enough communication, making sure we're all using the same language, and that we're hearing each other. We don't know how this plays out. Perhaps the doctor corrected her or just laughed and said, 'Oh, you're hilarious,' and assumed that she understood him. But what I would prefer that we start moving towards is, first of all, being at the same level. He did that really well, right? He's at the same level. They're both seated. Being at the same level as the people that we are offering our services to, physically at the same level. This photo still isn't perfect, but it's what I could find for unlicensed free use on Google, where these two people are sitting at the same level, and I've decided that the guy in the striped shirt is listening to the guy in the green shirt because I want to convey how important it is for us to listen, for us to hear and actively engage and allow for this person to express themselves. So how do we develop a protocol that kind of looks something like this? You can click on that link. That'll take you to HEAL's protocol toolkit. Just as an idea, as an example of how you might go about that. I asterisked response because response doesn't mean you swoop in, rescue, and save anyone. Your response should be first to listen and meet this person where they are and see what your patient needs. You want to train your clinical and non-clinical staff. I offered one link to one training that is free, and it's 22 minutes in case you're trying to train everyone. That's thousands of people at most places, and that's pretty tough to do, but just like as a 101 resource. And then when you develop your protocol, you monitor it, you evaluate it, you revise the protocol, and you repeat. Monitor, evaluate, revise, repeat. Monitor, evaluate, revise, repeat. We can always be doing better, and so we should always be trying to respond better, and a lot of that response just looks like listening, which I think is a great transition for me to pass it on to Holly, who's going to talk a little bit more about the approach, because now I hope that I've set it up for you all that you believe that screening and assessment is really useful and interesting when we can do it right, but you may not need it. I can tell you that I clinically don't use it for trafficking. I use an approach, and I try to let the patient tell me where we should be going. I'm going to turn it over to you now, Holly.
Great. Thanks, McKinney. So again, my name is Holly Gibbs, and I'm the Director of Dignity Health's Human Trafficking Response Program. And I know a lot about designing a protocol, evaluating it, refining it, and then repeating it over and over and over. That's what we did for 3+ years. So our anti-trafficking program, or our program to educate staff about human trafficking and to protect victims and empower survivors in our healthcare settings, that program launched in 2014. I came on board in 2015. And when I came on board, an algorithm had already been developed based on best practices, best knowledge, and consulting with subject matter experts in the field. It was, I believe, a 2-page algorithm describing to staff what to do if they suspected a patient was a victim of human trafficking. And so I put together another document called a human trafficking case record, and I asked staff to complete this case record anytime they identified a patient that they suspected to be a victim of labor trafficking. And the case record was designed to capture information from frontline staff about how they felt about the procedural steps, what went right, what went wrong, what could or should be done differently. And so the 2-page algorithm turned into other types of algorithms. Then it turned into like more of a standard operating procedure, and we just continued to refine that. And now we have an abuse, neglect, and violence policy. So one of the key learnings from our human trafficking case records is that it doesn't make sense to have a protocol specific to human trafficking because, as McKinney mentioned, it's not our job, it's not the health professional's job to investigate the situation to figure out exactly what type of violence is going on. If we have a concern for some type of abuse, neglect, or violence, then we should be following the same procedural steps, right? So that's what we have in place now, an abuse, neglect, and violence policy. And a portion of that policy is this PAIR tool procedure. And what the PAIR tool describes is it offers guidance to health professionals on how to offer victim assistance to a patient in a way that's trauma-informed. So all the steps that have gone into this tool are from our frontline staff all across our system. We have nearly 40 hospitals across 3 states, and we partnered with Heal Trafficking and Pacific Survivor Center to design this tool. So Pacific Survivor Center is a clinic based in Honolulu that provides services to victims of various types of violence, including human trafficking. And then Heal Trafficking is a national organization of health professionals addressing human trafficking in the healthcare space. So the PAIR tool is available for download here from our website. And if you look in the bottom left corner, there's a copy there as well that you can download. So, sorry, let me just point out, I have highlighted here social workers because ideally it is the social worker who's walking into the room and having this conversation with the patient to offer assistance. But in hospital settings, well, first of all, in hospital settings, we don't always have 24-hour social work coverage. So after hours, it may be a nurse, a physician, a chaplain, even a patient navigator who's in the position to have this private conversation with the patient. Or if you're working in a physician's office setting or some other ambulatory setting, there may not be social workers at all. So our policy at Dignity Health is currently set up to state that the first step is to document concerns in Cerner as normal. Step 2, make a referral to social work. And then step 3, offer assistance to the patient in a trauma-informed manner using the PAIR tool. So the PAIR tool was designed to reflect guiding principles of a trauma-informed approach. As described by the Substance Abuse and Mental Health Services Administration, these are the guiding principles of a trauma-informed approach: safety, trustworthiness and transparency, collaboration, empowerment, voice, and choice. So we're not just making decisions around this patient, right? We're including them. We're empowering them to be a part of the conversation. So if you're not familiar with this term, a trauma-informed approach, that's key to all acts of patient care, including acts with patients who have experienced violence. So if you want to learn more, there's lots of resources available from SAMHSA. This is one small booklet called Concept of Trauma and Guidance for a Trauma-Informed Approach. It's free to download. I highly recommend it. Another great resource describing a trauma-informed approach in the healthcare setting is the Center for Healthcare Strategies. They have a website dedicated to trauma-informed approaches. Okay, so the PAIR tool is also based on a universal education approach. This focuses on educating the patient about whatever type of violence you're concerned about prior to or in lieu of screening or assessments. You know, it's been our experience, again, this tool, our policy is based on 3+ years of cases that we've had at Dignity Health, and it's more often the case that the patient either denied victimization or did disclose victimization but didn't accept services, but other times the patient was completely shut down and not communicating at all. So I think that even if you have the best list of screening questions in front of you, your patient is going to disclose what's going on. Chances are your patients know what you're trying to get at, and they're only going to disclose if they're ready to disclose. So the goal is to have an informative and normalizing conversation with patients in order to create an experience where it feels natural to share what's going on. And of course, these conversations need to be culturally appropriate, developmentally appropriate, and so on. And we recommend use of brochures or safety cards to help facilitate dialogue and normalize the conversation. Okay, so PAIR stands for Provide Privacy, Educate, Ask, Respect, and Respond. So you'll see on the PAIR tool itself, it's 3 pages, and these main steps are on the first page. You'll see a double asterisk sprinkled throughout those steps, because this private conversation with the patient, it can end at any time for any number of reasons. And it's at that time when the conversation ends that you want to follow through on things like internal reporting. So notify your supervisor about what's going on, or notify security about safety concerns, or notify patient safety. Whatever the situation is calling for, you can reach out to your local stakeholder, your internal stakeholders. Then you want to follow through on mandated reporting. And then, of course, you want to continue health services. So for those of you who know me, you know that I'm a survivor of sex trafficking. I was trafficked when I was 14 years old, and I use those experiences in everything that I do at Dignity Health. And so in my experience as a 14-year-old victim recovered by law enforcement, I had everybody involved in my case. I had 3 police districts involved in my case. I was in the emergency department. I'm sure child welfare was involved as well. I just don't have clear memories of them being involved. So I had all these agencies, all these professionals around me, but nobody was talking to me. Nobody was asking me what I needed. Nobody was asking me or, describing any sort of options available to me. I felt just as powerless in their hands as I did in my trafficker's hands in Atlantic City. So mandated reporting is important, very important, but it can't be the only thing that we're doing. Someone needs to talk to the patient about what's available to them, empower them to make choices, to seek assistance, to seek escape, whatever it is they're looking for. Okay, so the first step is to provide a safe and private setting. Ideally, this is a private room with closed doors. That's not always available in a hospital setting, so as private as possible. If the patient's companion refuses to be separated, this may be an indicator of abuse or violence. It isn't always the case. Doesn't necessarily mean it definitely is going on, but it may be. So consider strategies to separate the patient in a non-threatening manner. For example, state a requirement for a private exam, or request the patient accompany you alone for some kind of a test, a pregnancy test, a urine test, radiology, and so on. Or request that the companion assist with something outside of the room, like registration forms. Prioritize the patient's safety. So if the companion still refuses to be separated, then it may not be safe to insist on separation. Again, there's the double asterisks. If you can't get the companion out of the room, then the conversation may never begin. And in that case, we're going to inform our internal resources about safety concerns, and we're going to follow through on mandated reporting, and then we're going to continue health services. Remember that safety is the first guiding principle of a trauma-informed approach. That means safety for the patient, safety for staff, safety for visitors, and so on. So in this case, it's just best to continue health services as normal. Educate the patient in a way that normalizes sharing of the information. So in the PAIR tool itself, there's lots of little tips around guidance and also tips for example statements. So for example, in the provide privacy section, it's highly recommended to explain limits to confidentiality to your patient. That can truly create a safe and trustworthy and transparent setting. So here's an example statement to educating your patient about violence. I educate all of my patients about whatever it is, say human trafficking, because violence is so common in our society and it has a big impact on our health and well-being. It's recommended to use a brochure to review information and then to offer the brochure to the patient or leave the brochure, on a table near the patient. I've heard arguments against and for both approaches. Just in case this is ever an issue. So, sorry, let me back up. A brochure that I like a lot is from the FBI. It's written in a way where the audience is a potential victim. It includes the National Human Trafficking Hotline, and it's available in numerous languages. But there's lots of resources out there around human trafficking and other types of violence. So I would recommend researching and finding the ones that work best for you and your patient population. So once this conversation is over, you can say, just in case this is ever an issue for you or someone you know, would you like to take this brochure? Saying or someone you know is important because it allows the patient to accept information without disclosing what's going on. For me, at age 14, if I had stumbled into a clinic in Atlantic City and someone had this conversation with me, I don't know if I would have disclosed what was going on. But if someone used that particular FBI brochure with me, and that FBI brochure says, have you ever been forced or pressured into prostitution? I understood that this man that convinced me to run away from home actually tricked me and pressured me into prostitution. He ordered me into prostitution. I wouldn't have identified with the term forced, but I would have identified with pressured and prostitution. I wouldn't have identified with human trafficking or exploitation. So if the patient declines, respect the patient's decision. And again, there's a double asterisk there because it may be that you're having, so this tool is meant for patients that are at high risk of victimization or showing actual indicators of victimization. So let's say you just educated a person who's at high risk and they don't seem open to the conversation. You may not feel comfortable pushing them past that point. Allow time for discussion. So after reviewing the information, allow time for open discussion, especially if the patient is exhibiting risk factors or indicators, and especially if you work in a setting that offers long-term care and services like a clinic or a physician's office where you have that extra time to discuss with your patient. So another example statement, is there anything you'd like to share with me? Do you feel like anyone is hurting your health or well-being? And if the patient is very open to conversation and questions, then it may be at this point you may want to consider a screening tool or an assessment tool. If the patient is exhibiting significant risk factors or any indicators of abuse, neglect, or violence, then you want to ask about those safety concerns regardless of the setting that you work in, hospitals, long-term care settings. So another example statement, I've noticed, and then talk about what you're noticing. I've noticed that, you have a tattoo that seems to indicate, someone's initials and a crown, and I know that's associated with some forms of violence, and your boyfriend seems really controlling. I'm concerned for your safety. You don't have to share details with me, but I'd like to connect you with resources. Would you like to speak with? And then know who the resources are, your local resources, the national resources, and have some preparation around what to expect. Will this agency respond on site if they're interested in speaking with them? Will it have to be a conversation by phone? And if you don't know those details, be transparent about that. I don't know all of our local resources, but I can contact, say, the national hotline. We can call them together. If the person says no, just let them know that if they change their minds, that they can let you know anytime that you're there to help. In other words, you don't want to keep having the conversation, keep coming around and saying, are you ready now? Are you ready now? We've had those cases, and the patient can feel like badgered. And the final step is to respect and respond. And this can be the most difficult step. If the patient denies victimization or declines assistance, respect their decisions. This is key to a trauma-informed approach. Again, remember, it's about safety, trustworthiness, empowerment, voice, and choice. A victimized person may be fearful or reluctant to share information for so many reasons, trauma bonding or fear of retaliation by the abuser. And research has shown that leaving an abusive partner, that can be the most dangerous time for a victim of intimate partner violence. So if the patient denies victimization or declines assistance, and you're still concerned about their safety, at that point you may want to offer a hotline card, something small that just has key information about victim resources. And this is a shoe card that's available from the Blue campaign. You can click on this website here to access that. If the patient does accept or request assistance, whenever possible, provide a warm referral, meaning a personal introduction to the local agency or whatever agency, whether it's sitting on the phone and transferring from the agency to the patient. So again, it's important to identify ahead of time those resources that are available. And page 3 of the PAIR tool offers some national hotlines, and it offers some space for you to enter information about your local resources. For hospital staff, if the patient discloses victimization and they're sitting there waiting to speak with someone, consider offering them another opportunity to opt out of the directory, meaning to be confidential. We have had cases where patients agreed to speak with an advocate and someone arrived and found them in the hospital and they left with that person. So that's a lot of information about this tool, but I hope you walk away with this fun picture from our conference last year in Mesa, Arizona, where we launched our PAIR tool and someone had the opportunity to wear the PAIR costume. So remember, provide privacy, educate, ask, respect, and respond. And with that, I'll hand it off to Stephanie, the operator, to give instructions about how to ask questions.
Thank you. Again, as a quick reminder, if you'd like to ask a question, you may submit your question via the Q&A pod located to the left-hand side of your webinar platform.
Thank you again to both of our speakers, and they have graciously shared their contact information. If you all have any questions, again, resources are available for download. So I just want to start off our Q&A section. Again, we encourage everybody to engage, and I'll start off with our first question. Are cultural differences taken into account when completing a screen?
I think Holly and I can both talk about this a little bit. No, not the tools that currently exist, not yet. If we try to take some knowledge from the folks who have done similar work in other forms of intimate partner violence, interpersonal violence, and we look at, for example, intimate partner violence, you can see that a lot of the work started out with English-speaking populations, but they broadened that to include validated work with other languages, including Spanish language, including, I think people talk very commonly about women being victimized via IPV, but that work has broadened out to include other genders, including men, and other races and ethnicities, so that it's more useful and more applicable to a broader group of folks. That being said, sometimes as you make a population for whom a screening tool is validated more diverse, you might lose sensitivity. This is getting a little into the researchy weeds, but it's important for us to think about when we come up with, for example, protocols even, is it culturally appropriate for the population that we serve at our site? When I work at one hospital that serves one population, asking a certain set of questions has no bearing on whether or not someone's being trafficked and has more bearing on what culture they're coming from, what their cultural experience is. I agree that culturally relevant tools are needed. and we don't have those fully yet. But there are some areas in which I think that folks who do know their populations well, even though their tools aren't validated, they've built the tool based on cases and experiences clinically that they've seen specific to their population, which means that their tool may not be exportable to another setting.
Yeah, this is Holly. I'll just say the PAIR tool emphasizes the importance of being developmentally appropriate and culturally appropriate in conversations.
Thank you both. Moving on to next. As you implement these approaches and protocols in your health systems and hospitals, how do you measure success? And what outcome measures are you tracking?
So this is Holly. I am very excited to share that we received a grant from the Department of Justice to vet the effectiveness of our new policy and procedure that includes the PAIR tool procedure. So we hope that we can provide some evidence to show whether or not this approach is effective very soon.
From my perspective as a researcher, it's important that whenever we're engaging in research and we're looking at outcomes that impact people, which I think is most human research, we should be asking the people about whom we're asking the questions what they want us to measure. So if we go back to even just what Holly said about her own experience and what she would have liked, those would have been measures of success, right? So setting up a system such that, like a QI system, quality insurance, or a QA, quality assurance, or however you name it at your facility, such that you're examining each case, and that might mean asking the person in the moment because you might not get long-term follow-up, and saying what went well for you, what didn't you like, and starting there to help figure out what your outcome should be. The measures might be something like, did someone sit down and talk with you and listen to you? Did someone offer you resources in general? It may not be that someone is saying, yeah, they didn't swoop in and save the day, because I don't think that anyone's going to say that. But so thinking about it from the perspective of what do the patients want us to measure as success, instead of having us imagine that we're going to figure this all out and do it right on our own.
Thank you. Now with that, can you speak or share how you manage situations for adolescents who decline services but are subject to mandatory reporting?
Holly, do you want to?
Sure. So I would say it's all built into these PAIR steps, right? Whether it's an underage person that you suspect to be a victim and they're declining services, or an elderly patient, a vulnerable adult, someone who's coming in with wounds or injuries. We want to educate them about whatever type of violence we're concerned about, and then offer to assist them in gaining access to these resources, especially a warm referral. It's a best practice. As a victim myself, I can say, I don't know if I would have picked up the phone and called a particular agency, but had I met them one-on-one, that would have made a huge difference, even a connection over the phone. So again, we're going to have this private conversation with the patient, educate them, offer assistance, meet them where they're at, so respect their decisions to decline services, but of course follow through on internal reporting, mandated reporting, and then continuing health services.
Yeah, I definitely agree with Holly. We have to meet patients where they are. I know that for clinicians there is this concern about mandated reporting, about what we can actually do. So a few principles to keep in mind in general when working with minors is, number one, minors can make decisions. They technically by law can't consent unless they're emancipated, but for this, for trafficking specifically, it doesn't matter whether they're emancipated or not. So I generally start all my conversations that I think are going to go any kind of way, or when I see it's going some kind of way, with letting folks know about what I am a mandated reporter. Frankly, a lot of adolescents are aware of what I have to report about already. but making sure that I've said that up front, then they are in control of what information I receive. And I can still have my suspicions and still feel like I need to report, in which case I do nothing in secret. I don't keep that a secret, that report, and so I say, like, well, I actually have to make a report about my concern for XYZ, because again, for the most part, we'll never know for sure that something has or hasn't happened. And so I let them know, this is what I have to do. Do you want to be a part of that report? So offering them some agency shows respect for the fact that they've been surviving without us for this long, and they probably will keep surviving without me, regardless of what I do. And then if they do want to get involved, then great, like it's smooth sailing from there, right? If they don't want to get involved, I actually don't have the power to detain anyone as a physician. I am not law enforcement. I am not security. I can't do that. What I can do is say, okay, well, let's still do the medical care or the psych care that you came for. I can make the report later. My job is not to hold someone hostage. It actually doesn't, number one, help the health care that they need to receive, and two, it doesn't make it a place that they're going to come back to when they actually do want to change something about their situation.
Yeah, and I would add, we have redefined what success looks like to us at Dignity Health. Success is not completely dependent on this person making that crucial decision to disclose or accept services in that moment. Our definition of success is if we recognized a person who's at risk or showing indicators of violence, educating that person about the type of violence, and then offering to assist them with accessing resources. And if we're providing them with information about those resources, there's a chance that they may say, no, I don't want any help, and then 12 hours later, go to the resource, contact the resource that you've just educated them about.
Thank you both. Do you have any opinions or recommendations for initial screening questions by registration, patient access, or triage for patients in a hospital setting? For example, similar to IPV screening questions that we ask all our patients.
So personally, I do not, because there's nothing validated that's comprehensive. And again, the Greenbaum tool is specific to certain chief complaints, so it wouldn't be appropriate for initial screening at registration. And the way the tool works, it's not just questions, it's also looking into chart. It's like a chart review as well. So no. Again, that's why I really wanted to stress the import of listening and listening with your ears and your eyes and your heart, like listening with your whole body to the patient. I did give you my disclosure at the beginning about Robert Wood Johnson and Emergency Medicine Foundation, so I am attempting to develop and validate a screening tool that's comprehensive for adults. So maybe in a year-ish or so, I can give you an answer on that, but at this point, I don't think it's necessary, frankly, or appropriate. Professionally, I would not use an unvalidated screening tool.
I agree with McKinney, and I would add that at Dignity Health, we educate all of our staff about human trafficking, both labor and sex trafficking. We're asking all staff, patient registration, security staff, on up to nurses, physicians, and social workers to be on the lookout for signs and symptoms of all types of violence, including human trafficking.
Thank you, and I just want to follow up that question with how was the Greenbaum tool validated, and what gold standard was it compared to?
Great question, which I think should always be every question anytime someone tells you a tool is validated. If they can't describe it to you, it probably wasn't validated. So I left the link. There's a link in there so you can go in and read. They've published on this a few times, actually. Long story short, they've compared the questions to how it performs with an expert interviewer doing an assessment, so an expert in trafficking. For trafficking, for this, it's actually a really tricky thing to do because there isn't a gold standard that doesn't require an expert to use. So the Vera Institute created the Trafficking Victim Identification Tool, which is validated for a social service agency, for example, but it requires an expert to use it. So it's akin to that, what they did for the Greenbaum tool, which was they said these are the questions that we're either asking or using chart review for, and comparing that to when an expert in trafficking interviews this patient, do they determine trafficking or not? There isn't really another tool, another standard besides a lawyer, which is, again, it's the same. It's about having an expert in trafficking. I hope that that clarifies, but if not, that is definitely available by reading. If you want to email me, I can give you all the articles related.
Okay, next question. Do you have any suggestions for grant funding sources for hospitals interested in implementing screening and navigation efforts?
I mean, anyone that gives out money. It depends on how you're framing your question, what your research question is. That is actually an entire webinar on how to attain grant funding, period, much less in a topical area. So I would say NIH might be interested, NIJ could be interested, foundations are commonly interested in the area of trafficking in general. And I would also say that depending on what you're doing, you don't need grant funding. Your hospital, many hospitals, I don't know about all, especially if it's at an academic center, is always trying to do quality improvement work. And a lot of this stuff doesn't really take much funding, and so you may not need as much money as you think. I would suggest doing the upfront work of having a few roundtables with folks in your hospital, including survivors, and figuring out what you actually want to do and what do you want to study and learn that hasn't already been studied and learned before you seek out, millions of dollars.
All right. Why do you think there have not been more efforts to develop tools to use in healthcare or for law enforcement?
It's expensive. So just to give you an idea, in healthcare, I think it's two reasons. Number one, it's expensive. Human trafficking is one form of interpersonal violence, and it's fairly rare in the sense of how many people actually experience it in comparison to how many people we see in general. It's not rare in the sense that, it is common enough that I would say that it happens more than we think, for sure. In the study that we're doing, our minimum needed to enroll based on a predicted prevalence, because we don't actually know, because we can't know, is a little over 3,000. In order to do that in a validated way, that takes money. And it takes time and patience. Validation is not something that happens because I interviewed 20 people. So that's number one. Number two, I would argue that if we're using something like the PAIR tool, if we're using that kind of approach, you don't really, we can't screen for everything in a hospital, clinic, or office. There's horrible things that happen every day. And our job as clinicians is to be observant and then patient and listen and connect to resources very often. And so if hospitals are thinking about it, for example, from that perspective, they may recognize that it's not really worth putting in that much effort. I can tell you that I'm doing it because I'm scared of unvalidated tools and the impact that has on individual patients and on public health numbers and how programming gets developed because of unvalidated tools.
All right. Any closing comments from our speakers? We thank everybody for participating in the Q&A. Well, with that,
Holly, you go first.
Oh, go ahead.
I would just add maybe that Heal Trafficking and Dignity Health have partnered to offer a training and technical assistance time for those in the healthcare field that are interested in implementing these kinds of programs and protocols. So if you're interested in that, just reach out to me and I can share the details. This is Holly again, by the way.
Thanks, Holly. That's a good reminder. I'm McKinney. I would say two things. Number one, please, when you're developing whatever your protocols are, always include survivors meaningfully from the beginning so you don't go down the wrong path. And always, always, always include labor trafficking not as an afterthought, but it's a real trauma that a lot of our patients who are trafficked are experiencing. And if we're only screening for sex trafficking, we're doing them a disservice. It's not fair. And the second thing is remain calm. This has been a problem for centuries, human trafficking, and frankly, clinicians have been seeing patients the entire time. So if we do our jobs to the best of our capacity and in a way that Holly has talked with us about, it's going to be okay for that each individual patient. And we're not going to, healthcare is not going to solve trafficking. So we just remain calm. We don't need to, there's no emergency we need to rush into coming up with a protocol tomorrow. It's actually an unsafe way to serve our patients.
Thank you both for a wonderful and informative presentation and all of your great insight. Just want to remind everybody to check out our website. We will be posting a playback of this on our website, and you have our contact information, and we appreciate you joining us today. And that concludes our webinar. Stephanie?
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.